It's a great privilege and honor to introduce Professor Manoj Karmakar. He is the Professor, Consultant Anesthesiologist and Director of Pediatric Anesthesia, Department of Anesthesia Intensive Care, the Chinese University of Hong Kong, Prince of Wales Hospital, and he has been there for several years. Huge number of papers, original blocks, and he's a popular a speaker amongst all the conferences. Manoj, please.
Thank you, Dr. Diwan, for the kind introduction. Good morning, ladies and gentlemen. It's nice to see so many of you here at this early hour of this morning, nice and fresh. And I have some important and interesting message for you. I see there are a lot of empty seats because people may think, oh, this is just a brachial plexus session. How mistaken they are. There's a saying, if you snooze, you lose. I have no conflict of interest to declare relative to this talk. As I said, I have been an editor for these two books, so it's not going to influence the way I'm going to say today, what I'm going to say today. This is a meeting we organize in Hong Kong. It's a festival of spine and paravertebral sonography for anesthesia, for pain medicine, for musculoskeletal physicians, for rheumatologists, orthopedics, everything. And this is an interesting date, ladies and gentlemen, as you can see. Sorry. How do I go back? Oops. It's all the twos you can see there. It's a very interesting. That's the day. If you're planning to be at this meeting, you should be in Hong Kong. 20th of February, 2020. Okay. As I alluded to yesterday, we have now moved on from one side of the bridge to the other. I think it's fair to say so. And so has regional anesthesia. When you look at brachial plexus sonography, this is the first reported paper in the radiology literature. I'd like you to focus, ladies and gentlemen, on this aspect of the article. It was first published in 1998, where Dr. Shepard performed sagittal scan, transverse scan, and coronal scans and demonstrated elements of the brachial plexus in 1998. Although he was able to demonstrate the C5 to C7 nerve route, he also described that the C8 and T1 nerve routes were more difficult to define. The first reported use of ultrasound in anesthesia, and in particular regional anesthesia, was in 1978 by Dr. Lee Grange from Tygerberg in the Republic of South Africa. It was Stephen Capral who actually introduced two-dimensional ultrasound imaging, which we so frequently use today. 25 years have gone by. We've learned a lot of lessons, and most of you are familiar with some of the outcomes that are with respect to upper and lower extremity blocks. New techniques have been described, and in fact, regional anesthesia has gone global. I travel the world, so I can attest to the fact that ultrasound has become the modality of choice when it comes to regional anesthesia. Today I'm going to introduce you to some aspects of brachial plexus sonography using high-definition ultrasound that many of you may not have access to. And if you do have access, you will also be able to do so. Now, let's take, for example, the interscalene block that is very frequently performed, and there have been several lectures yesterday about this technique, and my good friend Paul Kessler very eloquently reviewed some of the literature. When you perform an interscalene block, you look at the neural elements within the interscalene groove. It's described as a groove and is often described as though the neural elements are sandwiched between the scalenus anterior and the scalenus medius. But is it so simple, ladies and gentlemen? Second, the neural elements that you are seeing within the interscalene groove, what are they? Sure, they are the elements of the brachial plexus. Are they the roots? Are they the trunks? Are they the divisions? And which one of these elements represent the individual component of the brachial plexus? Today, unfortunately, we say this is the brachial plexus. Some describe it as the roots. As a neurologist pointed out the other day, these are really not the roots per se. They are actually the ventral rami of the nerve roots. Secondly, when you look at the interscalene groove, what are these elements? I think today it would not cut it if you said they are, describe it as different things. We have to be very specific. And how do you do this? I'm going to show you, ladies and gentlemen. It's also been described as the traffic light sign or the stoplight sign, where each one of these individual components represents C5, 6, 7. Is it true? Let's question this. When you insert a needle that is inserted in plane, you can see here it's coming through the scalenus medius, and you insert it into the groove between the C5 and C6, as described in the literature. You can also see there's another hypoechoic structure within the scalenus medius. This structure is actually gaining more attention these days because if you happen to injure this dorsal scapular nerve, the patient may have long-term injury relating to this. This structure may not be seen so clearly in many ultrasound systems that you use. So looking out for this structure, if you were doing your interscalene block like so, is an important step in the whole process of doing these blocks. Next, when you insert the needle, we often described that you place the needle tip between the two neural components. You inject the local anesthetic. We focus on low volume to minimize hemidiaphragmatic paresis, etc. As you can see, we're injecting the local anesthetic. But there are also data today to say that maybe such an aggressive approach is not desirable. You can just be within the groove and you can be extrafascial and you can still get comparable analgesia and comparable outcomes in the postoperative period. So such an aggressive approach where you deliberately put the needle between the two neural components may lead to long-term outcomes, neurological sequelae in the postoperative period. Once you inject the local anesthetic, it spreads within the interscalene groove, produces the effect that we are so familiar with. But the question here, ladies and gentlemen, as I alluded to before, what are these structures? Now, in the interest of time, I can't review the literature for you, what people have described, but in a nutshell, I can tell you, people have described it, and in fact, these are my peers, my colleagues, who in the past have described them as nerve roots, some have described them as trunks, some have described them as C5, 6, 7, 8, T1, the entire brachial plexus within the groove. So now let's try and see how we can do a systematic examination of the interscalene groove, identify the individual elements, starting from the ventral roots, the trunks, division, the chords. I will try and limit myself to above the clavicle, and then discuss some of the newer targets that have been described for local anesthetic injection. Now, when you look at the brachial plexus, this is an anatomical picture everyone here in the audience, I assume, is very familiar with. The C5, 6, 7, 8, and T1, the ventral rami contribute to the brachial plexus. You have a superior trunk, middle trunk, and an inferior trunk. And they divide into chords, they divide into divisions, and they fuse together to form the three chords of the brachial plexus. I'd like you to focus on the part of the upper trunk. This is the upper trunk. It divides, the suprascapular nerve emerges from here, divides into an anterior and a posterior division to produce the anatomical arrangement that Vesalius described in 1555. So since then, this is the anatomical picture every one of you have read in Gray's Anatomy in most anatomical textbooks. The arrangement is SAP. But is it correct? Next, C8 and T1 are very difficult to define. But if you see here, the C8, after it emerges from the foramina, lies on top of the neck of the first rib. The T1 comes from underneath, and lying on top of the lung, it will fuse with the C8 to form the inferior trunk. Now, most of you are aware the inferior trunk is quite elusive in some way because you can't see it. It often escapes when you do supraclavicular brachial plexus block, and it depends today now on the technique that you use. So, I will try and show you a method in which you can very clearly define these anatomical structures. Dr. Carlo Franco from the Cook County Hospital performed some cadaveric dissection to identify what these neural elements were when you look at the stoplight sign. he found that the C5 root was the smallest of the three, 5, 6, 7, 8, if you may. He also found that the C6 and C7 often provided evidence of intra-root splitting. That means he could often find that the C6 and 7 would divide into two, but not the C5. Like you see here, the C5 is the smallest amongst the C5, 6, and 7. The C6 and C7 often showed macroscopic evidence of intra-root splitting. There we go. So now if we look at this interscalene groove with these neural components and the stoplight sign, Dr. Franco said that the stoplight sign has 3 lights, but actually in many cases there are only 2 lights that make up these, or neural components that make this stoplight sign. It may have clinical significance because if you assume the two parts of the C6 is 6 and 7, and you put your needle between the two, that could lead to really severe, devastating neurological sequelae post-op. So more than important that you are able to very clearly define which are the elements of the brachial plexus that you are visualizing. Okay, now with this stage set, now let's look at the SAP arrangement that I alluded to. Now, traditionally, this is described as the suprascapular nerve anterior and posterior division, as shown in this cartoon. But Dr. Franco, again, in his work, showed that the suprascapular nerve emerges, or it trifurcates into the suprascapular nerve. But look here, he's labeled this as the posterior and the anterior divisions. He must be a brave man to challenge Vesalius, who described this in 1555. But he was very confident, and he said, actually, he's not the one who described this SPA arrangement. So many of you here are quite familiar with the spa. People go there to rejuvenate themselves. So this is often described as the spa arrangement of the upper part of the brachial plexus, where you are seeing the suprascapular nerve posterior anterior division. Dr. Hanna, a neurologist, or a neurosurgeon, if I may, he did several cadaveric, actually about 40 or 50 dissections, and he found very consistently, actually, the arrangement is SPA and it's not SAP. He even challenged Vesalius, saying that this diagram is incorrect and there is a need for a new diagram to be created for the brachial plexus. Now, for anesthesiologists, it may not be so important. But you can look at a neurosurgeon. He thinks he's cutting off the anterior division, but he actually is cutting off the posterior division. You understand what I'm saying? Yeah? So, also, the trifurcation is not a simple case of trifurcation, the anatomical variation where the suprascapular nerve emerges not only from the upper trunk, but also from the posterior division or the anterior division. So variability is a spice of life when it comes to anatomy that we all know. So when you do high definition sonography of the brachial plexus and you're trying to identify the brachial plexus element, we usually perform a transverse oblique scan, and it becomes a coronal oblique scan. Now in the past, I always used to say in my courses that as anesthesiologists, we have no need for a coronal plane scanning. But how wrong I was. Today, we are going to perform a scan which is a coronal oblique scan. There are certain sonoanatomic landmarks that we need to be able to define to accurately identify the neural elements. This is a pioneering work, in my opinion, by Dr. Carlo Martellini, where he demonstrated the C7 is a key anatomical landmark when it comes to identifying the cervical vertebra or the neural elements in the neck, because the C7 has only a very prominent posterior tubercle. The anterior tubercle is either rudimentary or it is absent. And you can see here, like the pillar of Martellini, you can see the posterior tubercle of the C7 here. And they can see in a CT image like so. So the neural element that is anterior to this is the ventral rami of the C7 nerve root. You can see in anatomical images that have been rendered at the same level, CT images that have been rendered at the same level. You can see the C7 nerve root as it emerges. The ventral rami is located on it before it enters the groove. Also, it's very closely related to the vertebral artery and the vertebral vein. before these vessels enter the foramina of transversorium. The next key sonoanatomical landmark is the C6 transverse process. As we all know, the C6 transverse process is a very prominent anterior tubercle, and through it, the C6 nerve root emerges. This is the Chesniak's tubercle, as some describe it. Again, in anatomical section rendered at that level, you can see the very prominent C6 anterior tubercle, and in a CT image, you can also see that. So these two are the key anatomical landmarks, the C7 transverse process, posterior tubercle, and the anterior tubercle of the C6. So what lessons have we learned so far? We find that the C5 is the smallest of the ventral rami of C5, 6, and 7. The C6 and 7 show evidence of intra-root splitting. The stoplight sign is actually made up of two nerves, neural elements. The SAP arrangements may be incorrect. It is the spar of the brachial plexus is the arrangement most frequently seen. And the unique sonomorphology of the C7 and C6 I've already demonstrated to you. Also, I showed you the C8 lies on top of the first rib, close to the neck of the rib. So when we perform a scan, this is how the patient is positioned. The neck turned away to the opposite side slightly, lying supine with the arm by the side. We perform the transverse oblique scan like you start performing a supraclavicular brachial plexus block. So if that's the image that you want to have in your mind. So from the foot end, this is how it may look. And it's done in a sequence. So this is from the side view. You can see this is a view of the supraclavicular fossa. And then you sweep the transducer. As I always say, this is a sweeping motion. Okay? So we start from the supraclavicular area and you sweep it kephalat to the C5. And then you sweep it back towards the supraclavicular fossa. So that you can then see that it may look something like this, where you are starting from the supraclavicular fossa and then slowly fanning it up towards the C5. Now let's try and look at what are the neural elements we will come to see. Now this is the three neural elements you can see. This is the C7 transverse process, so this is the C7 nerve root. This is the C6 ventral rami. This is the C5 ventral rami. It'll keep looping. So you would agree with me that now we can very accurately identify C7. This is C6. This is C5. C5 is the smallest of the three. Also, C7 has only one posterior tubercle. The C6 has a very prominent anterior tubercle. You agree with me? So now you see how you can very accurately identify C5, 6, and 7. So when you see these individual elements, you can see that the C5 is actually a small nerve, and the C5 transverse process, both the anterior and posterior tubercle, are also relatively small. The C6 is a very prominent anterior tubercle, and often you see the C6 ventral rami in relation to it. Now let's take a look at the divisions. This is a very interesting picture I took in Siem Reap many years ago in Cambodia. It reminded me of all the divisions of the various nerves. So the nerve, let's take a look at. Now you can identify C5, you can identify C6 and C7. So now let's see what happens to these individual elements. So I like, ladies and gentlemen, to focus on one element at a time. Our brain cannot process too many things at the same time. So look at C5 and see what happens to it. Look at C6 and see what happens to it. And you will see here that the C6 is showing a bifid appearance. The C6 is starting to divide. So you have three lights, but actually there are two nerves, which is absolutely correct what Dr. Carlo Franco said. This is in vivo, although his work was in cadavers. You can see this is C5 and this is C6. It's dividing into its two components. And this is C6 because you can see the C7 is below here. This is C7. All right, C5 is the smallest of the three. Also, I like you to focus on not only the neural elements. You can see here there is a sliver of muscle between the groove. And this is very commonly seen. We've done many volunteer examinations, and in our data collection we found that this interscalene groove is not a sandwiched, a distinct space that is often described. Actually, it's septated by muscles. You'll see either from the scalenus anterior or from the scalenus medius, portion of the nerve muscle actually invaginates into this groove. Also, the vertebral artery, as I showed you, is very closely related to the C7. So that's another anatomical landmark that you can use. What happens now? We've seen the C5 and C6, and we've seen the C6 actually is bifid and often starts to divide. The C5 and 6 join to form the upper trunk, and then it trifurcates into SPA. As I said, you can only focus on one neural element. So, ladies and gentlemen, this is a video that is going to show you how the upper trunk is formed. You can see this is C7, so this is C6, this is C5. As I scan CODAD, you can see the C5 and C6 join together to form the upper trunk, and it trifurcates into a suprascapular nerve, the posterior and the anterior division. This will loop around, so you will be able to focus on that element. The upper trunk is a relatively large nerve, and it divides into three components, SPA. So, you probably never thought, before you walked into this door, into this room, that you would be able to be so precise in being able to identify anterior posterior division. Now, as anesthesiologist, does it really matter? I think you may think it doesn't, but really we can be so precise, we can be so targeted, we can, in fact, if we can do it with such precision and consistency, regional anesthesia may change. We may have to rewrite the textbooks again because we'll be doing very targeted injections. Okay, that's a philosophical way of looking at it. This is a picture from my hometown. I always talk about this. This is from Arunachal Pradesh. This is Parashuram Kund for many of you. So many of you pay pilgrimage to Parashuram Kund. You take a dip and we all get very pious, I guess. Now let's look at the upper trunk, middle trunk, and the C8 arrangement. Now you know how the upper trunk is formed. So the neural element, which is the C7, actually lives below the upper trunk, is the middle trunk, because the C7 continues as the middle trunk. So you can see the upper trunk here. This is the middle trunk, and this is C8. I showed you that the C8 lives on top of the first rib. Can you see that osseous element? This is the C8, and you can see that invagination of the muscle into the groove again. So this is C8, this is the middle trunk, this is the upper trunk. Okay, so I've labeled it for you. The upper trunk is often large in circumference. This is the middle trunk, and this is the C8. Now, although there are descriptions of radiologists having defined or visualized the C8 and T1, there are no illustrations of showing you how the C8 looks or how it is formed or the inferior trunk is formed. Our work, I believe, is the first documented evidence of the visualization of the C8 in vivo, and secondly, how the C8 and T1 join together to form the inferior trunk. Again, as I mentioned, these are some sono-anatomical landmarks, and even Dr. Carlo Martellini in his study said that he could see it in about 80% of the cases, the C8, and the T1 in about 40%. There are also studies in radiology looking at the cross-sectional area of these nerve roots, and normograms have been described. In fact, Dr. Sun and their group said that when you see these neural elements in relation to the first rib, it's usually the upper trunk, middle trunk, and the C8 that lives on top of the first rib. So now we've been doing this axial oblique or the transverse oblique scan. So now we're going to convert it into a slightly coronal appearance, okay? So that you are able to look at not only the C8, but the T1 as it emerges from below to on top of the lung to join the T1, C8 on top of the first rib to become the inferior trunk and reside at the corner pocket that is often described. You can see here in this cadaver dissection, the C8 is on top of the first rib, T1 comes and joins to form the inferior trunk. So this is going to be our focus because this is the last part of it that we're going to see. So you can see the C8 here. Focus on an individual element. As I turn the probe into a coronal axis, I can see the lung and the pleura there, and you will see it like a little mice coming out from its burrow. You'll see the T1 there, you see the T1 here. It comes out from underneath to lie on top of the pleura or the dome of the lung. I'll loop it again, and you can see here the T1 is coming out to very close to the C8. So the T1 will now join with the C8 to form the inferior trunk, and it will go and lie next to the subclavian artery in this lateral corner pocket, as you see there. Focus on this area. You will see the T1 coming from below joins the C8 to form the inferior trunk. So this is a captured image. You can see now the T1 here, the C8. This is the middle trunk. This is the superior suprascapular nerve upper trunk and the posterior division of the upper trunk, and this is the anterior division. So you can see a host of different nerves that you can now identify. Now, many a times we say these are a bunch of grapes. Now you can see here the mystery of this bunch of grapes are actually becoming exposed. We can now accurately define it. Maybe for neurologists, people who are involved with dynamic examination of the brachial plexus, this is going to be very, very, very important, because now they can identify individual elements starting from the C5 ventral rami all the way down to the T1 and the formation of the upper, middle, and lower trunk. So let me just show you the sequence in captured image. You can see the C5, you can see the C6 with this very prominent anterior tubercle. You can see the C7 with the posterior tubercle here. It's closely related to the vertebral artery. The arrangement of the upper trunk, middle trunk, and the C8, and they all form together the C8, which lies on top of the first rib. As the T1 emerges from below, it goes on to join the C8. As you see in this sequence of images, the T1 is moving up to join the C8 to form the inferior trunk at the corner pocket. So now if you look at the suprascapular, the bundle of nerves at the supraclavicular fossa, you will see from a lateral to medial, maybe the posterior division, the anterior division of the upper trunk, the inferior trunk, and these elements will be part of the middle trunk. Or they may be the two divisions of the middle trunk. So, ladies and gentlemen, I hope I have demonstrated to you that it is possible to very accurately define the individual elements of the brachial plexus. So I say, we've exposed the brachial plexus in many ways. You can see the ventral rami of C5, you can see the ventral rami of C6, you can recognize the ventral rami of C7, you can recognize the ventral rami of C8, and for the first time I've illustrated to you that this is the T1 can also be demonstrated. The upper trunk is a large nerve, fusion of C5 to C6. The middle trunk just lies below the inferior trunk, the superior trunk, and in fact this point is often described as the Erb's point, where the C5 and C6 join together to form the upper trunk, and this is where most of the Erb's paralysis with the traction injuries occur. You can also see the inferior trunk form at the corner pocket, the origin of the suprascapular nerve, and the two divisions of the upper trunk, and the middle trunk, which eventually divides into its anterior-posterior division. I, for one, even one and a half years ago, before we did this work, never really believed that we could really define these nerves. So it is truly possible. So we've presented this work in at the American Society of Meeting, and a manuscript relating to this is currently under consideration. And our work shows that, in volunteers, shows that in up to about 80% of individual you can see, about 90% of individual you can see the suprascapular nerve. So targeted suprascapular nerve blocks can be done more anteriorly than posteriorly for those of you who are pain physicians here. The inferior trunk is also seen in about 60% of individuals. You can see here a large proportion, you can see that. So maybe inferior trunk blocks where inferior trunk escape may be a fact of history in the near future. Because if you can accurately identify it, you can accurately inject it, then maybe it will not be an issue. Dr. Paul Kessler talked about superior trunk block, and in the interest of time I can't go into more details of it, but you can see we can identify the superior trunk very clearly, the upper trunk very clearly. Where the upper trunk is formed, it is quite far from the phrenic nerve. It's quite lateral from the phrenic nerve. So an injection to produce an upper trunk block is certainly feasible, and there is some early work that it produces comparable analgesia. Also, when you look about these individual elements, being able to be so objective about this, may help physicians who do dynamic examination, who are looking for injuries to the brachial plexus, are looking at inflammatory changes in the brachial plexus. Hopefully, this work will be able to define some of these elements, and they will be able to more objectively diagnose some of the pathology that the patients may come with. Finally, my thought about the future, with being so objective, is that if we can be so objective about identifying these elements, I think all our techniques that we do will be very targeted, using small volumes of local anesthetic, and we may have to rewrite our textbooks, and you may have to learn regional anesthesia all over again. Thank you, ladies and gentlemen.